Greetings, everyone. Welcome to the 228th session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Marsha Oberholzer. Dr. Marsha is joining us all the way from South Africa, where she has completed her optometric studies, which includes bachelor's, master's, as well as the PhD from the University of Johannesburg. She has a vast experience, I would say, in private practice. And she also has, and I think she's also an academician. She currently also teaches postgraduate and also PhD students. But at the professional upfront, she is with Alcon. She is appointed as the Vision Care Professional Education and Product Training Head for GEM at Alcon. She has been awarded various awards during her career. I think there are a couple of them to name, but I think the most important ones, which is the Excellence in Teaching and Learning Award in the category of junior lecturer at the university level, and a couple of awards at the Alcon AAA and GEM awards for the Alcon Hero Award in 2022. With all that vast experience and being a teacher herself, being into academia, she's here with us sharing about a very interesting topic. I think this was launched a couple of years back by the World Council of Optometry and Alcon as a joint project, which is the dry eye wheel. And I think today was a great day to have Dr. Marsha, because we are starting to celebrate the World Optometry Week. Today is the first day of our World Optometry Week, and I think it could not have been better to have Dr. Marsha with us sharing the dry eye wheel with us. So thank you, Dr. Marsha, for joining us today. And I will just leave the screen time to you, please.
Good morning, good day, good afternoon, good evening to all of you. And thank you, Fakturin, for the kind introduction. It is a privilege for me to be part of the OOLS for 2024, and thank you very much for the invitation. I am Dr. Marsha Oberholzer, as he has said, and I am the Vision Care Professional Education and Product Training Head for GEM at Alcon. So the reason why I chose the topic of the dry eye wheel for the session today was led by all the advancements in dry eye disease during the last decade. The dry eye enthusiasts among us know that effective dry eye disease diagnosis and management has evolved a lot, up to the point where it is now a well-structured approach that is outlined by the TFOS reports. So, however, the need for a tool to help novice and expert dry eye practitioners mitigate, measure, and manage dry eye disease has been recognized. And this is when Alcon and the World Council of Optometry put heads together to develop the dry eye wheel, a tool that assists eye care professionals in the mitigation, measurement, and management of dry eye. I would like to acknowledge my colleague, Jonathan Bench from the UK, and one of Alcon's key opinion leaders, Alberto Riccioni from the University of Birmingham, that made this material available to me after it was introduced at the IACL 4th World Congress in June 2023. So let's look at the agenda for this session. We will first look at reimagining the tear film and dry eye, as well as the real-world impact on patients, and then proceed to the dry eye wheel tool. I know that all of us see a lot of tear film pictures and presentations every time we listen to a dry eye talk. However, to know your future, you must know your past. So let's take a moment to see how far we have come since the first time the tear film was introduced and graphically represented to what we know about the tear film today. So let's reimagine the tear film. In 1977, we thought that the tear film consists of 3 layers: the lipid, the aqueous, and the mucin layers. The mucin layer was strictly not seen as part of the fluid tear film, and the film thickness was estimated at approximately 6 to 7 microns. Then, in 1997, the interpretation of the tear film layer was altered as more and more research was done on the tear film. Increasing interest in the tear film as a research topic, as well as the recognition of dry eye as a condition at the time, was brought a lot of new insights to the compilation of this fluid layer. In 1997, the layers were not anymore really seen as separate layers, but more as a viscoelastic gel with a top lipid layer and mucins as soluble components of the tear layer. The approximate thickness of the tear film was estimated as 2 to 6 microns at the time. So, and then after the last meeting of DUs in 2017, this model was again reimagined and defined as a single dynamic functional unit. We almost went back to the original thinking of separate layers with a mucoaqueous layer and a surface lipid layer. We also now understand that the tear layer is a non-Newtonian shear thinning layer and that the tear viscosity decreases with shear rate during blinking. Now, you may think, what do I mean if I talk about a non-Newtonian fluid? So a non-Newtonian fluid is a fluid with variable viscosity. So this layer has the ability to increase and decrease its viscosity, almost acting like a rubber band. This characteristic makes the tear film durable during the blinking of the eyelids as it stretches and compresses the tear film every time the lids blink over the tear layer. We now also estimate that the tear film has a thickness of about 3 microns. So my colleague Jonathan Bench, that many of you may be familiar with, had a wonderful idea to help the audiences of our trainings to understand the tear film model a little bit better by representing it as he calls it a fish tank model. So during the IACO 4th World Congress, I filmed him explaining this model, and this has meant a lot to other ECPs and learners from optometry schools. So I'd like to share this with you and represent it to you as well. So enjoy.
So let's go.
Okay, brilliant. So what we have here is a cross section of the tear film. Okay, so we've got, it feels like it's a magic trick, but obviously it's not. It is a cross section of the tear film. And I need you to use your imagination. And why I need you to use your imagination is because of this. When I think about the tear film, I struggle to comprehend how thin it is. And I deliberately use the word thin because we talk about the thickness of the tear film being circa 3 to 7 microns, but that's not thick, that's thin. That's less than a tenth of a human hair. So the way that I try and get my head around things is I try to shrink myself down so that I can get inside of that structure. Can you imagine if you could have like virtual reality, you could look around, it would all make so much more sense if we could be like that. A bit like the film Inner Space back in the 1980s, where he gets shrunk down and injected, or a bit like Ant-Man, I suppose. But if I can't do that, which is impossible, what can we do to make the tear film bigger? So this is my cross section. So this is my 3 to 7 microns, and we're gonna build the tear film as a result of this. So if we've got the tear film here, the bottom must be our ocular surface. And on the ocular surface, we know it's not smooth. So my tank's not smooth. I've got gravel in here to represent it. Let's think about the microvilli that are doing their lovely fronds wafting movement across that ocular surface. And we also know that mucins are being released into the tear film, which is kind of the multicolored gravel that we've got down here, all the different mucins that are being put into that tear film. But that would be a 3-layer model, wouldn't it? The mucin layer, and then what would come next? Come on, Thomas, what would be next? Water, the aqueous phase. Now actually, we know it's a mucoaqueous phase. So what we really want is for this to blend into a mucoaqueous phase. So to help us, we need to add some aqueous. So let's put some water into our model. Now, this is showing how the mucins and the aqueous all start to mix together to create that beautiful mucoaqueous phase. So we've got our corneal surface moving up through our mucoaqueous phase, and we're getting up to the top layer, the top element of our tear film. And what you can see, if you look carefully, I just do that as well, it will help, is that we're getting an overflow of our aqueous, mucoaqueous phase, which means it's going into the atmosphere, because this is not our tear film out here. So we've got evaporation. So in order to maintain this situation, what do we need to do? We need that final part of the tear film, which is what? What would you say?
Lipid layer.
Lipid layer. Now that lipid layer creates a thin film of oil across the surface. Now I can't make oil balance on here, but I'm going to use this cling film or food wrap and to illustrate that. Now, also what I think is kind of interesting is if this is the 3 to 7 microns, then this is probably not too far away from the scale of what the lipid layer would be across the top. So I'm going to put my lipid layer onto our cross section. And when we do that, we create a situation of homeostatic balance where we have everything in equilibrium. But what you'll start to notice is that this looks like it wants to break because it's bulging. So there's pressure, there's stress being put onto the lipid layer. So if we had a break in the lipid layer, what we would end up having is this mucoaqueous space evaporating away again, which would cause us to have a problem with the stability of our tears. So when we begin to think about the tear film, if we understand the structure, because we can see it a little bit bigger, and we understand where the problem is, the fragility in its structure, we can also begin to think about the management approach that we might take. So anything that's got an issue or involvement of the lipid layer, we're going to want to think about lipid-containing artificial tears or lubricating eye drops. If we've got a problem with the volume, the bulk, we're going to want to replace more aqueous into that, and that's where we're going to use drops for aqueous deficiency. The really curious thing, just generally, is that if we've got 86% of all dry eye having an evaporative component, so it's some issue with the lipid layer, how come we've got 90+% of all products for aqueous deficient dry eye? So think about what you're prescribing, think about when you're prescribing, and think about how and why it's going to make a difference. And that is just a bit of a silly way of demonstrating the dry ice tear film.
So I love that model. I really think that it really helps us to understand and get inside the tear layer a little bit. So we have now looked at the different models of the tear film over the years and how it has evolved. But similarly to thinking that dry eye causes scratchy and red eyes in the past, we know today that the real-world impact of dry eye disease goes much further than just a scratchy or a red eye. Dry eye disease has an impact on so many facets of dry eye patients' lives. So let's look a little bit at what are these real-world impacting factors. What do we mean if we say real-world impact? This impact refers to how dry eye disease may change or influence our lives or the lives of our patients in many ways. We think of dry eye disease prevalence, we think of quality of life of the patient, mental health and medication, physical factors like obesity and eye rubbing, and lastly also social factors like smoking. In the table on the right of the screen, you can see a summary of 6 important studies that looked at the impact of dry eye disease on different races and in different geographical locations. Here you can see that the prevalence of dry eye disease ranges from 8.7% in Iran to 30% in China. And this is only for the locations that were included in these respective studies. So the reported prevalence of dry eye will always vary depending on the paper that you review. The different reported prevalence may be explained by variabilities within each of the study cohorts, looking at age or gender or geographical location. But in average, prevalence is commonly reported to be around 1 in 4, so 25%, or about 1 in 5 people, so 20% globally. This chart then shows the reported prevalence in different countries using the data that was available in peer-reviewed studies by the Tear Film and Ocular Surface, or TFOS as we know it, and Dry Eye Workshop 2 or DUCE 2 report that was published in 2017. And you can also have a quick look at the countries that most of the audience may come from. I mean, we've got South Africa here that maybe some of my colleagues have logged on, or South Korea, or Japan, or Asia, Southeast Asia. So there's lots of this that has been compiled and reported in different reports and different peer-reviewed articles. So the real-world impact goes much further and looks at the impact of patients with dry eye disease on quality of life. So here we see the results of a study showing that the impact of dry eye disease translates not only to an uncomfortable and painful eye, but then also impacts on the psychological, physical, and social life activities of a patient, especially if we consider reading and writing, professional work, driving ability, and then watching TV. But how bad is this really? Is this really bad? Is this comparable to other diseases or other conditions? And the answer is yes. If you look on the right of your screen, you will see that severe dry eye disease may be compared to severe angina and moderate dry eye to moderate angina. So gone are the days that we think that dry eyes merely causes red or uncomfortable eyes. It may actually relate to the discomfort caused by these named quite serious conditions. Let's look at some mental health issues. A study looking at the global burden of diseases, injuries, and risk factors has shown that depression is ranked within the top 25 leading causes of burden worldwide in 2019. Dry eye disease has been linked to depression, and 5 studies report depression in 29% of dry eye disease sufferers. However, this is more focused at symptoms rather at clinical signs. So is this real dry eye, or is this just the experience of the patient being depressive, also reporting discomfort in the eye? So then there was a study done by Gaylor et al. Patients known with depression was treated for dry eye symptoms and signs. The results of the study showed that the dry eye symptoms and signs improved in depressive patients being treated over time in both groups that were treated with omega-3 oils and received placebo treatments. So, however, depressive symptoms remained unchanged. That suggests that at least one of these studies, with its own limitations, improved dry eye symptoms and signs did not directly translate to improved depression scores. If we look at physical factors, it's necessary for us to look at obesity, as so many people worldwide is affected by this. And it's sad to think, because this is a preventable condition. I think the most shocking statistic on this slide is the third bullet, where we see that 39 million children under the age of 5 years were found overweight or obese in 2020. Obesity has been linked to abnormalities in meibomian gland dysfunction and eyelid architecture. And the same is also true for comorbid conditions like sleep apnea, patients that's using a CPAP, that may also contribute to this association between obesity, meibomian gland dysfunction, and eyelid architecture. Physical factors, looking at eye rubbing. And we know often patients rub their eyes when they are allergic, especially in South Africa. We have got patients with very high allergies, especially in certain parts of the country, where they rub themselves into keratoconus. So we know that eye rubbing modifies the ocular surface, inducing exacerbation of dry eye. Ocular allergy is linked to this, but also contact lens wear in some patients. So for these patients, education and awareness is of utmost importance to make them aware of the risks of eye rubbing. One has to look at social factors as well, especially smoking. Research shows that smoking habits are declining. However, smoking men are up to 5 times more than smoking women. Smoking also causes up to 8 million deaths per year and increases the likelihood of age-related macular degeneration. Interestingly, though, the relationship between smoking and dry eye is not strong, but vapors complain more of dry eye symptoms, reduced tear breakup time, and increased corneal staining compared to cigarette smokers. So let's call our dry eye patients the sufferers. The sufferers of dry eye disease often describes the most common symptoms, which we know, right? Is burning, irritation, dryness, red eye. However, we have to remember that these symptoms are perceived differently by every patient or sufferer. What may be burning to me may be painful to you, and the same thing may be gritty to the person next to you. And this is why clinical evaluation of these patients are so important, not just to look and send them away, but clinically evaluate these patients. We should not ask them how they are. We should evaluate them and see how they are. So in summary, dry eye may have a significant effect on patients' lives. It doesn't stop with the gritty or the sandy feeling, but reaches much further: quality of life, sleeping disorders, depressive symptoms, productivity loss, and even driving difficulties. We should be empathetic to these patients, evaluate them thoroughly, and pay attention to a sustainable and targeted management plan. So let's go on to the dry eye wheel, which is the reason why all of you are really here today. So the dry eye wheel has 3 parts: mitigation, measurement, and management. So let me introduce the dry eye wheel to you. This tool was developed by Alcon and the World Council of Optometry in a collaborative effort to enhance the mitigation, measurement, and management of dry eye disease, whether you are a novice or an expert dry eye practitioner. We know that dry eye is a chronic disease. It is a journey with your patient, and you will have to work with your patient in order to really manage him or her very well. This wheel is a process of mitigating and measuring the patient's dry eye disease, and then with this information gained, formulate an ideal management plan for the patient. When the patient returns after management was started, you will then again use the newly gained information from the patient, revise and streamline your management plan, and send the patient away with an amended management plan until we find a management plan that really addresses all of the patient's needs. The wheel has 3 different colored rings: bronze, silver, and gold. These 3 rings symbolizes the simplest through to the more complex approaches in mitigation, measurement, and management, according to severity. We always start on the outside with a bronze ring, where we have no additional investment, going to the silver ring, which has limited investment, and if necessary, even to the gold ring with more investment or referral for co-management with an ophthalmologist. Most patients, luckily, fall within the mild to moderate dry eye disease category and can easily be managed most of the time by implementing the bronze or the silver rings. So I've created a little video for you to help you navigate your way around the website and around the wheel. And after the video, I will talk you through it. And after the video, I'll present a QR code to you. So I would like you to also get your mobile phones ready, so that you can scan the QR code so that when we go through the wheel, you can navigate yourself through this wheel. Okay, so here you will see the address. So it's on the World Council of Optometry's website, and it's on dry eye wheel. Then you will see the full mitigation or the full dry eye wheel. And if you go down, the explanation of the wheel is there, as well as the rings. We also have a small little section that reminds you that bronze is silver, silver is moderate, bronze is simple, moderate, and complex. Then we've got the 3 sections, and mitigation is where we will always start, and it has been divided into 2 sections: triaging and risk factors. As for measurement, diagnosis, and subclassification, and for management, mild, moderate, and severe management. So if you go into mitigation, there is a nice explanation of what mitigation means, how it works, and then for each little icon that you click on, it gives you a nice explanation as to what is meant by this icon, from bronze to gold and silver. And then if we go on to the triaging, the same for triaging. Then if we go into measurement, what is very nice is all of the tests are being shown within the measurements, but also all of the norms or the expected normal values. So if you see that your patient is showing more corneal staining or a shorter non-invasive tear breakup time, all of the norms are stated within these little icons, which is very nice for you to refer back to if you are evaluating your patient. So we've got the tear meniscus, and we've got meibomian gland expression, and then also meibography that we are detailing out there for you. And then the last section would be management. So management here, again, as I've said, the bronze ring will be your mild dry eye disease patients, your silver will be your moderate, and your gold will be your severe dry eye patients. And for each of these, we've got different therapies or different strategies of management that you may use. And this is available to everyone across the world, and you are welcome to share this as well and also to use it for yourself. Okay, so here's the QR code. So for those of you that would like to scan the QR code with your phones or your mobile phones, you're welcome to do this. I'll give you a few seconds and then we will go into it. You can navigate yourself around while I'm doing the rest of the showing of the dry eye wheel. So you will see that this QR code brings you onto the World Council of Optometry's website, and it should automatically show up the dry eye wheel. Okay, good. So let's start with mitigation. The mitigation ring is divided in two parts, the risk factors and the triaging. In this part, we will establish the risk factors for dry eye disease in a patient, and then from there, triage to see if measurement and management of dry eye disease is indicated for this patient. In the risk factors section, many risk factors that increase the prevalence and that may serve as triggers for the dry eye disease are included. So ocular surface conditions may trigger the vicious circle of dry eye disease, and by evaluating the risk factors carefully, these may be reduced and have a smaller influence on the dry eye disease of the patient. So we will look at these risk factors shortly. Once we have a targeted history of the patient and their related symptoms, we can now conduct a differential diagnosis and allow prophylactic measures to reduce the ocular surface damage. So the risk factors have recently been updated after feedback was received from IACL and workshops held at BCLA in 2023. These risk factors include sleep, contact lens wear, and eye strain mainly as part of the bronze ring. Slightly deeper in the silver ring, we consider optimizing the environment and hormonal balance. And lastly, we can consider medication review. To mitigate the resultant dry eye disease aggravated by the risk factors, we would use questionnaires like the DEQ5 or the OSDI standardized questionnaires to look at the presence of dry eye disease and to attempt establishing the severity of this dry eye disease in a certain patient. According to all of this information now collected, a differential diagnosis would be made, and now we would do the prophylactic treatment for patients with high risks. If we go into measurement, the measurement part of the ring is once again divided into two subsections. The first one is measurements to diagnose the patient, and then measurements to subclassify the dry eye disease as evaporative or aqueous, or perhaps, mixed type dry eye. The diagnosis needs to be standardized so that the patients have a certainty of their disease, but also that they build trust with you as a clinician. So a standardized approach is necessary, and clinicians should regard this consistent approach as important. So often the assumption is that advanced technology is necessary for a robust diagnosis of dry eye disease, but this is not the truth. Diagnosis may follow after the completion of a standardized questionnaire or even the simple comfort of the blink test. So furthermore, diagnosis may be aided by an ocular surface damage assessment with ophthalmic stains and the assessment of tear film stability and osmolarity. but more about this just now. The subclassification is, of course, also important, and this will help you with your choice of management. Blink rate or completeness of blink, the tear volume, the meibomian gland expression, meibomian gland imaging, all of these tests will help us, or measurements will help us for the subclassification. Now, for me to demonstrate the next point, I would like to do a small little test with all of you. So I would like you to type an X in the chat box, but do not press enter or your return button yet. Just keep your finger on the button. So don't press the X yet. We are going to do a little test. I want you to close your eyes. And when I say go, in your head with your eyes closed, please count to 10 seconds. So when you reach 10 seconds, you hit the enter button and you keep your eyes closed until I ask you to open your eyes. I think over here, I'm just going to share a moment just so that I can see the chat box, if that's okay. So when I say go, do not press your X yet. Just put it in the chat box. Please don't press it yet. I'm going to open my my stopwatch. And when I say go, then you start counting until 10. And then when you get to 10 seconds, then you press your enter so that your X comes through to me. Okay, so get ready. And let's go. Okay, you can open your eyes. Okay, luckily what I wanted us to see was exactly what happened. So the first X I received at 6 seconds. So even though all of you counted up to 10, the first one I got at 6 seconds, and the last one I got at 20 seconds. So what is the moral of my story here? My 10 seconds and your 10 seconds is not the same. So we cannot measure any tear breakup time or any measurement where we have to measure in seconds by counting in our heads, because you see the patient, next week I see the patient if you're in a multi-professional practice, and my 10 seconds and your 10 seconds is not the same. So this comes back to standardized procedures. Please use a standardized procedure to do your results of the patients. If you have to make a count, please use a stopwatch or your mobile phone, because I received the first 10 at 6 seconds and the last one at 20 seconds. And a lot of those X's came in from 17, 18, 19 seconds. I think often we are scared that we're going to count too fast, and then we count slower, and then we count too slow. So use standardized protocols, use standardized methods of measurement. Okay. So if we look at the questionnaires and then the blink to diagnose the patient for dry eye disease diagnosis, thereafter, we will evaluate the quality of the blink of the patient. If the blink rate is elevated or the patient only blinks partially, this may translate to evaporative dry eye. Looking at the silver ring, we will look at the different stainings and their meanings as well as osmolarity. The subclassification will be evaporative if there's evidence of meibomian gland dysfunction, and it will be aqueous if the tear meniscus is too thin. The gold ring shows the staining of lissamine green, which I know is quite hard to get now globally. But we will look at the lissamine green conjunctival staining to subclassify evaporative dry eye. And we can also use then meibography for evaporative dry eye and also interferometry in aqueous dry eye. So the most often used questionnaires are the DEQ5 and also the OSDI scores. So I put them there I put them here for you, and I want to challenge you. I want you to print this out. They are readily available across the internet. They are standardized questionnaires available to anyone. So print them out and do the questionnaire yourselves. Whenever I have seen a group of people or a workshop at a big conference, we have made the patients or the audience fill this in themselves, because I often give this to patients, but they've never completed it themselves. So when I would ask before the time, how many of you do you think have got dry eyes? Then a third of people will put up their hand. But what we have realized is by filling in and completing these questionnaires ourselves, we realize that a lot of us have subclinical dry eye, where we don't necessarily present with symptoms as yet, or we're just not that cognizant or that attentive to our symptoms. When we fill in these questionnaires, then I often see up to 3/4 of the same venue, the same audience, putting up their hands to say, you know what, I got either mild, moderate, or severe dry eye. So I think it's also important for us to complete these questionnaires before we give it to our patients, because we need to understand and we need to go through the process ourselves. So I want to challenge you to do this when you get in the office tomorrow or later today. And I want you to complete these questionnaires and look at your scores. I've got the scores here for you. Obviously, some of them are variable depending on different articles and different reviewed articles, but this is kind of the scores that you can go according to for DOQ5 and for OSDI, and then evaluate yourself. So let's look at the silver and the gold rings more specifically and what the measurements will show us here. So in the silver ring, we've got non-invasive tear breakup time. So tear breakup time may also be done the old-fashioned way with fluorescein. However, it has been shown that non-invasive tear breakup time is more accurate for obvious reasons, and also more accurate as a measure of time, because we've now seen if we just count it 1, 2, 3, 4, then it may be variable across professionals or across ECPs. So I don't know if all of you are familiar with a Ratten filter. So going on to fluorescein staining, the visibility of staining is often enhanced by this Ratten filter. It's basically a certain yellow lens that we know is a Ratten filter, but if you use this, often the staining is much better visible. The staining or just the conjunctival, the stippling on the cornea is often easier to see through this Ratten filter. So you would put the patient on the biomicroscope or the slit lamp and basically just hold this filter between the microscope and the eye, and you will see this fluorescein staining lighting up. It's often used for RGP fittings as well. So some suppliers do supply these Ratten filters, and some laboratories even make them for their customers. So you can inquire if you're interested in this. Lastly, the tear lab. The tear lab is also now known as the Trucera. It is the same device. It uses the same little calibrated things for the tear lab. And this device is wonderful in measuring the osmolarity of the tears. And it is also seen as one of the most accurate instruments for the measurement of osmolarity. And if you go back to the ring and you click on osmolarity, you will see even the norm values are in the dry eye wheel. If we look at the subclassification part, we can look at evaporative subclassification, which is where you will see meibomian glandis expression to confirm evaporative dry eye disease. Or you can look at the tear meniscus height in aqueous deficient dry eye disease. So you may think, how do you measure this? There's a lot of software programs. I think in my country, the Genvis software is mostly used on the Keratograph 5. But there are more software programs that will actually measure the time and measure the tear meniscus and the height for you, and then give it out as the overview of the results at the end of the test. If we go on to the gold section, we see the lissamine green staining. And this is especially for conjunctival staining and to evaluate Mark's line. So evaluating Mark's line will also then aid in the diagnosis of lid wiper epitheliopathy, or LWE as we also know it. This would be characteristic characteristically be a marked line that is shown uneven distribution of the lissamine green. So a thinner, more demarcated line is more normal, whereas a thicker variability in thickness will more be diagnostic of lid wiper epitheliopathy. So for sub-classification, we can look at meibography as diagnostic of evaporative dry eye disease, and then interferometry diagnostic of aqueous deficient dry eye. So if we go on to the last section of the wheel, which is the management, management needs to be a staged approach with more severe conditioning, often requiring multiple treatments and not just one. So, however, the majority of patients may be managed with relatively simple strategies comprising ocular lubricants and lid hygiene. A management strategy should ideally not only be aimed at managing the severity of the disease, but should also be targeted towards the major underlying reasons why the patient suffers from dry eye disease. So furthermore, subtyping the disease into whether it is aqueous deficient, evaporative, or mixed type dry eye is also important to streamline this management strategy or the management plan. All of the information that we've gathered up to now will help us to assist in a choice of treatment. So the bronze, silver, and gold rings in the management section then refer to management strategies for mild dry eye in bronze, silver, moderate, and gold, severe dry eye. The bronze ring is often management strategies that is implemented by the patient himself or herself at home, whereas silver and gold management strategies often do require the help of an optometrist or an ophthalmologist, and usually comprises more of treatments or management strategies within the office environment or the testing room environment. So let's look at the bronze ring. As noted before, the ring is referred to as the management strategies for patients with mild dry eye, so often can be done at home. These include keeping rehydration top priority with artificial tears, omega oils, and humidifiers. It is also important to avoid environmental triggers like wind or smoke or air conditioners in office environments. Pay attention to increased blink rate, especially when working on digital devices. There are very nice blinking apps that would remind you when to blink and how to blink, and they remind you at certain time intervals to blink as well. So lid wipes may increase lid hygiene, and warm compressors then are always good to enhance the health of the meibomian glands. If we look at the silver ring, probably for patients with moderate dry eye disease that needs in-office treatment, we may consider IPL that causes the heating of especially the lids and meibomian glands. This heat assists in warming the meibum and increases the distraction of bacteria and mites like Demodex on the lids. The review of prescribed medications should be co-managed with an ophthalmologist and definitely not by us alone, especially these scripted medications that I've listed in this slide. Therapeutic contact lenses have become more and more popular in the treatment of dry eye disease, especially scleral lenses that we know has a tear reservoir between the lens and the cornea, hydrating the cornea constantly. And then for severe dry eyes, we refer to the gold ring. Here we see punctal plugs to retain tear fluid, lubricants, and other medications. And then more rare and complicated surgical interventions that will be managed by an ophthalmologist. So there you go. This is the dry eye wheel in full view. Will the dry eye wheel improve the way you approach dry eye disease? Will this make you more comfortable, and will this make it easier for you to structure a management plan for your patient? I would like to invite you to play around with this and also to get some friends and colleagues and other professionals to also try it out. And we are always open to feedback, and we would like to know what you think about the dry eye wheel and whether you feel it's useful and whether you can use it in practice. But I do want to close off with the following. At the end of the day, interpretations differ and patients differ. The dry eye wheel is a tool that gives us guidance as to how to mitigate, measure, and manage the patient with dry eye. There is no one size fits all. The guidelines are there, and we can assist as much as possible to help practitioners find their way around this disease. But it's up to the practitioner how much evaluation they are prepared to do, how much time they are prepared to spend, and how much effort they are willing to invest in this journey with their patients. Dry eye is not classified as a syndrome anymore. It has gained disease status in 2017, which makes us think, for those of us that do not suffer from dry eye, maybe it's time for us to take a step back, to really listen to our patients and to help them beat the symptoms of this disease. I thank you.
Thank you so much, Dr. Marsha, for that wonderful presentation. I think you covered the entire wheel from mitigation, measurement, as well as management. I think thank you so much for doing that for us today.
Thank you very much for having me.
Yeah. And yeah, the experiment was really great to know that everybody's measurement counting strategy is different. So that calls for the standardization, as you mentioned. It's really important to have a standardized test, which not only gives us a good value but also a repeatable value, because you are going to see your patients on a follow-up visit. So even you yourself, if you do these tests 2 times, it will be different, right?
Exactly. And if you're in a hurry, you're going to count faster. And if you're having a slow day, you're probably going to count a bit slower as well.
Yeah, so that's right. Okay. One question which came in quite earlier on the chat, it did ask about, you probably have covered it in the slides, but what are your views on using contact lenses as a mode of corrective measures for dry eye management? So I think you did tell about scleral lenses now being used for therapeutics and for dry eye management. Well, any views on using different type of contact lens materials, if I may put it that way, when we have a patient who has dry eyes?
Of course. So I think there are two answers to this question. The first one is, if we use soft lenses, we have to be careful that there's no infective agent or microorganism within the eye. If we use a soft contact lens, it would be to help the epithelium regenerate. So that's a very good way in using it, but it has to be monitored. You have to watch your patient, and it's not if I can say, a full-time or a long-term solution for dry eye. It is for those patients that has an incident where they have not been diagnosed, they haven't sought help, and they've got a lot of corneal staining, and you want those epithelial cells to regenerate. So then you can put a soft lens on. However, you have to be careful that there's no infections or inflammation in the eye. If we look at a scleral lens, this is probably the more popular way of using contact lenses as a treatment for dry eye, where we have the tear film in, between the cornea and the scleral lens, rehydrating that cornea the whole time. It has also been trialed, and this is to use some, lubricating drops within this, as well as the saline solution that you would use to fill.
Okay, let's do the questions, Dr. Marsha. If the first one is the kind of association with systemic illness or diseases. So there are a couple of dry eye patients who have an associated systemic conditions. Would there be a difference in management plan for such patients, in your opinion, or do you think that it's going to be the same as well?
So for systemic patients with systemic conditions, it's more difficult and it's much more complicated. If I think of systemic conditions, I think the patients that we see most in our chairs are possibly patients with Sjogren's disease, patients with arthritis, patients on chronic immunosuppressants, and also chronic cortisone tablets and cortisone treatments. So for those patients, we do include medication review. However, medication review, we can't change. We can review the medication and we can see which of the medications that the patient is using chronically are actually the medications that is causing the aggravated or the exacerbated dry eye symptoms. However, we cannot change it. We have to speak to the doctors, and the doctors will have to change if it's really uncontrollable. All that we can do is to help the patient manage the symptoms. We can't take the dry eye away from them because it's not caused by an anatomical, it's not a primary dry eye, it is a secondary dry eye. So the only thing that we can do is to support them best we can and to help them cope with the symptoms. You can see me? You can hear me? Yes.
Yeah.
Okay, so the main thing is to support your patients in helping them with the science and the clinical science and the symptoms, and to support them with best management you can for that. But if you're looking, most of them are being caused, is caused by aqueous deficiency dry eye. So most of those patients we do see with a slightly more aqueous deficient dry eye. So the treatment will stay the same, yes.
Right, yeah. And I think the next one is just looking at the dry eye wheel, because we have these different rings which are divided into the severity, in other words, in a simple way. Do they relate to each other, or would you decide on the treatment based on the severity, or how do they kind of help us in our decision making? So any thoughts over that?
So this is very much based as well on the DUS report. So if we know the DUS report has got 4 levels, level 1, 2, 3, 4, and we move on, we always start at level 1 and we move on to level 2 by the process of elimination. So firstly, we'll always try the bronze ring. We'll always try the first level treatments of the bronze ring, except if a patient comes to you and they've already tried these. And then we will go on to the silver and see if the patient is managed well or better, and then gold. But what I do want to emphasize is very often you will get patients that do a little bit better with this one of the silver and that one of the gold, or it's only guidelines. So we have to listen to our patients, and sometimes we may combine treatments or management strategies between the gold and the silver, or even between the silver and the bronze. But we usually start from the outside and then we move in as we see the patient is not managed and is not happy. Then we'll move more towards the gold. But it's 3 separate rings, but it's also not 3 separate rings. You may move in between the rings. This is just a guideline as to say, start here, then move there, and then lastly move to the gold. So always start with things that your patient can do at home. Help them to be compliant, educate them well, tell them a lot about the treatments and how they should do it. And then if it's not working, then you go more to your in-office treatments, your silver and your gold rings. Yeah,
right. And I think the importance of co-management sometimes, again, is quite highlighted, because if you want to do, help your patients with the prescription drug, for example, or punctal plugs, which you were mentioning, most of the optometry practices would have to refer it for co-management. So I think that gives us a huge opportunity to co-manage our patients with our fellow ophthalmologists and other eye care practitioners. So yeah, that's very important as well. Awesome, great. I'm just gonna share the next question. Yeah, we can hear you. Yeah.
Okay.
So in terms of the classification of the dry eye disease, you did start and mentioned about the 3 different types. I think most common is the evaporative, and then we have the aqueous deficiency, and we have the mixed one. So could we use this wheel in kind of better diagnosis as well? What's your opinion on that?
So for the measurement part of the wheel, we've also got the subclassification. So if we solely see only corneal staining, then we can go more towards the aqueous deficient dry eye path. But if we see anything that helps, that shows instability of the lipid layer, meibomian gland dysfunction, then we're going to go more the lipid route or the evaporative type dry eye. However, very often in patients, we see both. You may see the staining and you may see the reduced tear breakup time, and then we will classify it as mixed type dry eye. If we look at statistics around the globe, we know that 14%, 14% of patients are pure aqueous deficient, 36% are pure lipid, and 50% of our patients are mixed type dry eye. So they've got clinical signs of both aqueous and evaporative dry eye. So you're probably going to see a mixed type dry eye more often than just the one or the other. So if you do these measurements, you're probably going to see some evidence of both of these rather than just one or the other. So be prepared that every second patient that you see will probably be a mixed type dry eye. And I always say, when I teach students as well, is that it's very important for us to remember a patient may be either aqueous or lipid, but when they get older, when they start going onto medications, they start getting systemic diseases, comorbidities, anything like that, then the interplay from the medications, the systemic things are also there. So then they tend to also get more of a mixed type dry eye clinical picture if you look at the patient. And always remember to look at the patient holistically. The patient is not in your chair just with a dry eye. He's there because he's got arthritis, or he's got an immunosuppressive disease, or he's got something, or autoimmune disease that's bringing him there. It's not just the dry eye. It's not just two eyes sitting in your chair. It's a person. It's a family, a member. It is a holistic patient. So we have to look at everything, and then from there on, go and diagnose and manage the patient.
Right. Yeah. And I think we'll close with one question, which is more of a clinical question, but nevertheless, I think we can look for opinions. I think the relation of meibography with dry eye, in terms of, because you have in the ring, I guess it's in the
Meibography.
Yeah, so it's meibography plays nowadays is getting quite common because we have a lot of instruments available which can help us to image the meibomian glands. So what do you think would be the relationship between dry eyes and meibomian glands? Yeah.
So meibography, I think, is very important. I think it's probably one of the most important newer tests or newer inventions in tests that we've got available. And I think it is a very good indication of how bad the patient's dry eye is. I think meibography, when you get to the stage where you start doing meibography, I think the patient's diagnosis has been confirmed. The patient has definitely got moderate to severe type dry eye.
Yeah.
The meibography will be used often to see how severe this is and how severe the dry eye is. And what we would look for is if the meibomian glands are like little soldiers, that is good. And if they're equally long and they stretch up to almost a tarsal plate, then I often think of glaucoma if I talk about meibography, because glaucoma is an irreversible disease, and so is meibomian gland dysfunction. Once you start losing those meibomian glands, or they start getting shorter, or they start getting tortuous, then we can't really fix it. The only thing that we can do is try and stabilize it and not getting it, help it not to get worse. So yes, meibography is a telltale sign. It's probably, I see it as the future of diagnosing the severity of dry eye disease in a patient.
Yeah, very well agreed. So I think with that, thank you so much, Dr. Marsha, for joining us today and taking us through the subject of dry eye, plus explaining us the WCO and Alcon dry eye wheel. I think that helps. That would definitely help a lot of practitioners in practice to just open up and not only just for our personal, learning and understanding, but somehow I think it has a potential for educating patients as well. This is what is available. We could use it for your management. Yeah. So I think that had a huge potential in patient education as well. So thank you so much for sharing that with us today.
Thank you very much. Once again, apologize much for having me. Thank you for involving me in OOLS for 2024. It's really been a privilege and honor for me to be here. Thank you so much.
Pleasure is all ours. So thank you so much, everyone, for joining in today. We do have session planned over the next weekend. Until then, take care, be safe, and have a great Sunday evening ahead. Take care and
bye-bye. Thank you very much. Goodbye, everyone.
Bye, Dr. Marsha. Thank you. Have a great evening.